Good morning. Welcome to Carolina Breast Friends YouTube channel. Today, I would like to introduce two people. First, we have Dr. Shanice. She is a board-certified OBGYN focusing on sexual health as well as cancer survivor care. And then Chief Executive Officer of FemPharm, Jerry DiPiano. I hope I said that correctly. So welcome and thank you for joining us today. Jerry, I'd like to turn it over to you first.
Absolutely. So good morning. It's so nice to have the opportunity to meet with all of you and to introduce FemPharma and one of our Scientific Advisory Council members, Dr. Dana Shanis. FemPharma is a women's health care company that I founded a number of years ago. Prior to that, I was doing research and development in the prescription pharmaceutical industry. And when I started FemPharma #1, it was to explore opportunities to solve problems in women's health with prescription pharmaceuticals that we are still developing. So we do have a sister company that does research and development for women in diseases and disorders that disproportionately affect them. More recently, however, we took that technology and know-how and decided that we needed to provide more access to women, and particularly with women in natural and also chemical menopause or surgical menopause. We've developed an array of products that meet you where you are. Our products are made without hormones, and they are not required to have a doctor's prescription. However, we very much value the contributions of the medical community and practitioners like Dr. Shanis. So your physician will oftentimes recommend one of our Mia Vita products. Dr. Shanis, as I indicated, is one of our Scientific Advisory Council members. I met Dr. Shanis through the Living Beyond Breast Cancer organization, where I served as a board member for 8 years. And it was in that organization that I was able to meet many survivors and to appreciate the journey that you're on. And so with that, I'd like to turn it over to Dr. Shanis. Dana, thank you so much for agreeing to participate in this conversation.
Of course. Thank you so much for having me. So I'll give you a little bit of a brief background on me before we get started with the presentation. I am, as they said, a board-certified OBGYN. After my residency, I did a fellowship at the National Institutes of Health in the gynecologic care of cancer survivors. And since then, I have been seeing cancer survivors for over a decade. I actually started my own practice several years ago to focus on this population. And so this is something that I feel very passionate about, and I'm really glad to be able to share some information with you today. So I'm going to pull up my presentation, and hopefully everybody can see that. So let's get started. So the first, I always put this slide first. A person is considered a cancer survivor from the time of diagnosis through the rest of their life. And I think this is really important. If you take nothing else from the presentation today, it's that you don't need to wait until you're done your treatment, till you're done your surgery, till you're past this to start caring about your quality of life. I believe that there is more to surviving than just being alive. And I want you to feel that you have the right to want better for yourself throughout the whole process. Now, some days you may feel like surviving or being alive is enough, and that's okay. But when you feel that you want to work on that quality of life, I think that you should feel empowered to do so. So let's talk about the scope. So as of this year, there was almost 4 million female breast cancer survivors. And what's really great is that of women that were diagnosed between 2013 and 2019, 90% of them have survived at least 5 years. The CDC is actually estimating that by 2040, there will be an additional 1 million female breast cancer survivors. So you are not alone. It is a large group, and the good news is that survival is so high amongst this group. The bad news is that there is really a shortage of medical providers that are trained on how to care for cancer survivors. And what that means is that you will have to advocate for yourself at times and know what to ask for, because you may not be seeing a provider that has had training to know specifically what you're going through. So that's part of my goal today, is to give you some tools to have that discussion and to advocate for yourself so that you can make sure that you have your greatest health as well as quality of life. So I give presentations a lot to gynecologists, and I think that this is important to understand that there are stages of survival. There's acute survival, that's when you're diagnosed and undergoing treatment. There's a huge amount of fear and anxiety, but there's also side effects from the treatment. Then it becomes extended when you may be in remission, and that still has fear and anxiety. I think that doesn't go away. But then you may have toxicities from the previous treatment. And then there's a permanent survival where there may be late effects from the treatment and long-term risks, some of which I'll go over. I think it's important to understand that this is not linear. You may go in and out of these different stages. And some of the challenges that we find that vary through these stages is assuming a sick role. There may be days where you feel like you want to be in that sick role and other days when you don't. And that is a challenge both individually and then also within a relationship. If you do have a significant other, they are also going through this trauma and these stages, and that can really affect your relationship. Faith is another issue that I see kind of wave. For some people, faith gets stronger. For some people, their faith is tested, and some faith is not an issue. But it is something that may fluctuate through these different stages of survival. And then, unfortunately, in our current environment, getting healthcare is not cheap. And when you are sick and taking care of yourself, often that can interfere with employment. So this can really add a lot of stress and difficulty to trying to take the best care of yourself that you can. I think it's important to understand all these roles, to be sensitive about some of the challenges that you might be facing. So let's talk about ongoing gynecologic care, the things that I'm going to go over today. So while you are likely seeing an oncologist for follow-up for your breast cancer and monitoring, often as a gynecologist, I am the one who initially found the cancer and like to be on board with your follow-up and make sure that I'm aware that you are following through with your screening and everything as well. We'll talk a little bit about screening for new primary malignancies, and then we'll talk about the physical effects of treatment regarding your ovarian function, bleeding, and then we'll go into sexual health. We'll also talk a little bit about the psychosocial consequences, which are vast and can really affect a lot of your day-to-day quality of life as well as your physical health, and then talk about maintaining wellness in general. So before we get started on that, one thing that I do recommend is that you ask your oncologist for a survivorship care plan. This goes over what treatments you had, what the recommended follow-up is, and surveillance and all of that. That's really valuable, not only for us to know what you're going to, what treatments you underwent and what side effects and issues you might be facing, but also knowing about follow-up. If I see a patient and I know that they have their MRI scheduled for tomorrow, there might be a higher level of anxiety and something that really we need to address. And maybe if there's something else that is causing anxiety, we can table that for now. So the coordination between your care providers is really, really helpful for us to give you the most individualized and sensitive care that we can. This is available on the ASCO, the American Society of Clinical Oncology website. So you can actually just download it yourself and bring it to your oncologist if they don't offer that up for you. So let's talk about new malignancies. So unfortunately, once you've had breast cancer, you are at a higher risk for other cancers than the general population. And there's several reasons for that. One is that there might be risk factors in common. There can be genetic mutations or genetic links that are related to other cancers. It can also be carcinogenic effects from your cancer treatment. So what that means is it's really important to follow through with your cancer screening. And so in terms of your gynecologist, cervical cytology screening with a PAP plus or minus HPV, depending on your age and situation, is really important. I recommend that you get that done near the time of diagnosis as well, because having HPV prior to treatment increases your risk of developing issues later. And so your surveillance will be a little bit higher. Colon cancer and lung cancer screening, if indicated, is also really important to follow through with. I put the HPV vaccine here because that's something that a lot of people don't know, that the recommendations have been changed for the HPV vaccine to be given up to age 45. Now, I will tell you that I actually will recommend the HPV vaccine for females of any age because the risk is very low. And the HPV vaccine may decrease not only your risk of cervical cancer, but also anal cancer and head and neck cancer. So if you have never received the HPV vaccine, regardless of your age, it's something to bring up with your gynecologist. The really great news is that cancer survivors are more likely to actually do their testing, which may be that previous you think that it can't happen to you and now you understand it can, but it's really important that you do follow through with the recommended screening. And then also looking for some of those common risk factors, especially tobacco use. I'll talk about that a little bit later, but that increases your risk of a lot of different cancers. So that's something that you definitely want to discuss if you are using tobacco and feel that you're ready to quit. Now, I put this here. Most of you are likely going to get genetic testing in this day and age, and oncologists are very up on these recommendations. But this is valuable because there are some other cancers, such as ovarian or uterine, that may be associated with certain genetic conditions. And so if you have not had genetic testing, it is worth discussing with your oncologist if that would be indicated. There also is some recommendation amongst genetic counselors that if you have not had genetic testing in more than 10 years, it might be worth being reevaluated because there are more mutations that are being found every day. And so it may be worth checking for some of the new mutations that have been found. So let's talk about ovarian function, because this is one of the things that is going to affect your quality of life greatly. Now, when you are first diagnosed and first starting treatment, it is very possible that you are still fertile. If you have follicles in your ovary that are in the later stages, they may not respond to chemotherapy or the stress of what you're undergoing. So it is really important to use contraception. Now, I think it's also important to know that many people find that having sex is a stress reliever, and it is likely safe, and I'm going to talk about this more in a little bit, to engage in sexual activity throughout all of your treatment time. The only caveat to that is that some chemotherapy is in vaginal secretion, so that's worth talking to your oncologist about. But you should not assume that you cannot get pregnant just because you're undergoing this treatment. Now, acute ovarian failure can happen during or after treatment. And that just means that it is happening at this time. And it may be transient, it may come back, or it might be permanent. Now, I have here that it's stress induced, and I have that in quotes because psychological or physical stress can lead to disruption of ovarian function. So even if you are not undergoing chemotherapy, the stress of a diagnosis or the stress of surgery or radiation can still interrupt your ovarian function. So that is important to know. Premature ovarian failure is defined as ovarian failure at less than 40 years old. And so that can occur, and I'll talk about that a little bit in the next slide. Because ovarian function can vary during this time, it is important to discuss your uterine bleeding with your gynecologist. A disruption may be normal, but heavy bleeding could still be a sign of another issue, or could actually put you in, make you become anemic or deal with treatment less well. So it's something that you should just, regardless of what you're experiencing, you should discuss with your gynecologist. So let's talk about chemotherapy. So the risk of ovarian failure with chemotherapy is highest when you have high dose, long duration, or you're older at the age of getting chemotherapy. And there are certain agents that are more likely to cause issues to the ovaries than others. Chemotherapy-induced amenorrhea. So amenorrhea is the lack of a period for 3 months, occurs in a majority of patients that are getting chemotherapy. If you're under the age of 40, about 90% will get their periods back within 12 months of stopping the chemotherapy. If you're older than 40, the risk of premature menopause or of permanent menopause is much higher. But if less than 40, it can be between 10 to 45%, depending on which of those agents you are getting for chemotherapy. Now, the consequences of ovarian failure is menopause. And often the menopausal symptoms, if it's happening due to removal of the ovaries, if it's or chemotherapy, is more severe than if it had happened naturally over time. And you see in this picture here, basically menopausal symptoms can affect every tissue in your body. So hot flashes, night sweats, vaginal dryness are things that very commonly people know about, but it can also affect your hair and gums, your sleep, skin, everything in the body. So unfortunately, that's something that makes it very difficult sometimes when you're undergoing chemotherapy to know what is from the treatment and what is from the menopausal symptoms. Ovarian failure also can cause infertility, sexual dysfunction, and osteoporosis. And so this is something that is very important to discuss with your providers. Now, usually we diagnose ovarian failure by just clinical, by your history, but there are several different labs that we can test that are very accurate in cancer survivors for determining likelihood of return of ovarian function. So that's something that if you're in that year after chemo and you're not quite sure if you're going to have ovarian function return, checking your AMH, checking hormone levels may help us answer that question for you. Okay. So preventing infertility or fertility preservation is really important, especially for our young survivors that have not completed their childbearing yet. There's some data on giving a GnRH agonist or antagonist prior to chemotherapy that may protect the ovary. That's something that the data is kind of mixed, so it would depend on your specific situation. You can undergo embryo freezing if you do have a partner or want to use donor sperm. oocyte freezing has really advanced where it is much more effective and likely to produce a viable egg than it did in the past. So that's also something if you do not have a partner that you can do to preserve your fertility. There also are studies on ovarian tissue banking. So this is something, especially in very young patients, that you can actually freeze portions of the ovary and then reimplant that after treatments are completed. So just some things to think about and to know can be done to preserve your natural fertility prior to treatment. Then treatment for ovarian failure. Now, most patients, if I say the word hormones, will shudder, but there are different hormones and different ways of receiving hormone that can be safe and very, very effective for treating the symptoms of ovarian failure. So I would not assume just because you have a breast cancer that you can't have any hormonal treatment. The non-hormonal treatment I'll talk about in another slide, but there are various different non-hormonal treatments for menopausal symptoms, including many supplements that may be beneficial. Infertility treatments, IVF, surrogacy, adoption, are all ways of building a family. and worth discussing if that's important to you. And then osteoporosis, bisphosphonates, raloxifene can be helpful for that. So dealing with the effects of lack of estrogen. So for menopausal symptoms, SNRIs, so the different antidepressants. So SNRIs, SSRIs may be helpful for hot flashes, night sweats, insomnia, and some of the mood changes that happen. But you do have to be careful that SSRIs may interact with tamoxifen. Gabapentin is also something that has been studied for hot flashes, as well as Veoza, which is a newer medication. As well as there are lifestyle, diet changes, supplements, and also environmental changes that you can do to modify these menopausal symptoms. Now, I could do a whole, lecture on this alone, so please let me know if you have any specific questions. Now, for vaginal dryness, a vaginal estrogen ring or 10 microgram ovule can be very safe, and there's actually a lot of studies, even in women who have estrogen receptor positive breast cancers, this vaginal estrogen is likely safe. Now, the estrogen ring that I'm talking about is for local estrogen, not for systemic. There is also a systemic estrogen ring, and that is in a different category that you'd have to discuss with your oncologist and gynecologist. Now, in terms of osteoporosis, typically we are going to check a DEXA at baseline. So when you're diagnosed, and then every 2 years, if you're taking a aromatase inhibitor, or if you're premenopausal on tamoxifen or Lupron, or if you have chemotherapy-induced premature menopause. Now, FRAX score, I'm not sure if you're familiar, but that takes into other risk factors other than just your bone density scores, and can determine your risk of a fracture that may determine that more aggressive treatment is recommended and needed. So let's talk about the uterine effects of the hormonal treatment, such as aromatase inhibitors and Lupron. Typically, we do not recommend doing routine pelvic ultrasounds and endometrial biopsies. So this is why talking about your bleeding is very, very important. Patients on tamoxifen, if they are premenopausal, they're at increased risk of benign polyps. While they are benign, they can bleed significantly and cause anemia. So it is very important for you to discuss your bleeding. I know I've said that many times, but it's very important. If you are postmenopausal, there is an increased risk of endometrial cancer. So again, any postmenopausal bleeding needs to be addressed and likely biopsied. Raloxifene is less studied, but may not have that same risk of uterine cancer. So hopefully more data on that will be forthcoming. So moving on, let's talk about some of the psychological issues. Now, while I am not a psychologist or a psychiatrist, I would say that a lot of what we do as gynecologists involves psychology, because we are dealing with very, very personal issues that involve quality of life. And if you are not in good mental health, it is very hard to be in good physical health. So what we find that pain and fatigue are extremely common during and after cancer treatments, and as is depression, anxiety, and insomnia, which are not going to help how you're feeling overall. PTSD is extremely common with cancer, and it's important to differentiate that from depression and anxiety, because there's actually different physiological changes that happen with PTSD that that affect our health more, even more significantly, and it can be treated differently than depression and anxiety. What is really great is knowledge of this rate of depression and anxiety is increasing, and so many protocols with oncologists are now including antidepressants. So I am seeing a lot more patients who are already on an antidepressant, which I highly recommend when going through these issues. So that is very promising. Early menopause also is going to contribute to your mental health issues, with lack of sleep isn't going to make you feel very good, but it can also directly affect your mood with irritability, depression, and decreased libido. Also, body image plays a big role in our mental health. And the next slide, I'm going to talk about that a little bit. So I think that most of us would agree that this woman in this picture is still very beautiful. But I use this picture to show to gynecologists the mutilation and changes that occur in our body, and how somebody, when looking in the mirror, may not feel like themselves, but also be reminded of their vulnerability and a severe trauma that they went through. So it's important to understand that changes in how you see your body is correlated with depression and sexual dysfunction. And of course, I think it is important to work with the psychologist and psychiatrist to move towards acceptance. But I think it's also important to understand that this is common and something hard to overcome. What we also find that this interferes with relationships and how we interact with our partners. It is usually the case when I talk to partners of my patients that they actually still think that their partner is beautiful and sexy and amazing and strong, but they may be afraid to touch where there's a scar, or they may be afraid that the partner is not interested in being naked or being intimate. And so that really can affect your sexual activity as well as your relationship, which plays a big role in your mental health. Now, that's for those survivors that have a partner. If you do not yet have a partner, it may be difficult to develop intimacy with a new partner, and not just sexual intimacy, but also emotional intimacy. And that's a challenge that many patients of mine find that does take work to get through. So we're going to talk more about sexual health. That sexuality and sexual health is really important to quality of life across the board. And that does not necessarily mean with a partner. It can be your sexuality individually, but it is important to many people's identity. Depending on the study you look at, it is a majority to all of cancer survivors report some dysfunction. And what is very frustrating is that even when other measures of physical and emotional health, so even when you're done treatment, and even when your periods return, and even when your depression is treated, sexual dysfunction still may remain after that. And what's really tough is that most oncologists are not going to bring this up. And this is something I actually present at oncology conferences frequently on this topic. And I get asked all the time, you want me to talk about this with my patients? Are you crazy? And I do. I want them to talk about it. But if they don't feel comfortable treating it, they just need to say that it is common and that there are people like me who are comfortable in helping you. So don't be turned off that your oncologist doesn't bring it up or doesn't feel comfortable talking about it. It doesn't mean that it's not important and that there aren't things that we can do. I personally believe that talking about it early actually makes it less of an issue. Because when we are having dysfunction, when we are not working the way that we want to, that adds guilt and frustration, and that feeds back into our physiology and how our body responds to sexual activity. So when I am the one to actually diagnose a cancer, I bring up sexual health right from the start. And some people, are like, I'm not thinking about that now, and that's fine. But I think that understanding that it is okay to think about it, and for some, it's a great stress reliever. For some, it may not be something that they care about right now, and that either option is okay. But whatever you want it to look like, there are people and things that can be done to help. Now, with sexual health, it's really important to understand that it's very complex and multifactorial. So it involves not only desire and feeling attractive, but also being able to participate and functioning normally. So being able to get aroused, being able to have penetration without pain. And so if any part of that is disrupted, you may find that your sexual health is not where you want it to be. So what we find is with chemotherapy and hormone therapy, from the early menopause, hot flashes, painful, you may experience painful intercourse from dryness, decreased libido. You may actually have atrophy or stenosis, scarring of the vagina. You may have decreased lubrication. You may have urinary effects. So you may have leaking of urine during intercourse, which may be undesirable, and shortening and irritation of the vagina. With surgery, you may have changes in your bowel function, range of motion. So this is an interesting one. I had a patient who used to find that the most pleasurable position was to be on top of her partner and holding on to the headboard. But she found that after surgery, she had difficulty raising her arms in a way that she could support her body holding on to the headboard. And this caused her a lot of distress because every time that she went to go into this position that she really enjoyed, she was reminded of her surgery and her limitations. Now, with some simple preparation, she was able to find other ways to comfortably um, have have enjoyable intercourse, but it was really finding out what these individual issues were that allowed her to overcome that issue. So with surgery and going back to the ways that it can affect, many who get their ovaries removed will go into a severe menopause, and that causes all of those changes that we talked about above. The surgery itself can also cause pain, and loss of breast tissue or sensitivity and the nipple can affect. There are, we know of at least 5 pathways to orgasm in a woman, and one of them is through the breast tissue. And so if that was a big part of your sexual function previously, and that's taken away, then it may take relearning what other methods will feel pleasurable. So let's talk about what we can do to address it. So first of all, it's really important to know that resuming sexual activity is safe and is important to quality of life. So you should not feel bad wanting to resume sexual activity. On the other side, if you don't want to resume sexual activity, that's also okay. It's important to understand that it will be different at minimum after your treatment, and that it is very possible that you may have some difficulties in the sexual activity that you used to perform before your treatment. So what can you do? Number one is masturbate. Now, what I mean by masturbate is not just get to an orgasm as quickly as possible. What masturbation is exploring your body and looking for self-pleasure. The value of this is invaluable, basically, because you will find that there are new areas that might feel good that you hadn't explored before. When you do it on your own and not including a partner, that takes away some of the guilt, anxiety, and pressure that you might feel toward pleasing a partner, or fear that you are not fulfilling what they want. So masturbation is something I really recommend that everybody do, but I think that in a safe space, it does not have to end in an orgasm. Explore your body and see what feels good. Once you know what feels good, then you can communicate that to a partner. I recommend individual and couples counseling or sex therapy. If you can find an ASEX certified sex therapist, and especially there are several that are trained in cancer survivor care, you may find that you have to explain less of what you're going through, that they understand some of the common challenges that people experience. So that can be really beneficial, not just for you to get your feeling sexy and and libido back up, but also for ways to communicate and interact with a partner that will be conducive to you both being satisfied. Treating menopausal symptoms is really, really important, including vaginal dryness. So I'm going to say it again, that vaginal estrogen is okay if needed. Now, trying lubricants and vaginal moisturizers is very reasonable to do first. And for many, that is enough to deal with the dryness. But if not, vaginal estrogen is likely safe. There are also newer treatments of laser. Laser actually has been around for a while. I personally use the Mona Lisa laser, but there are various different ones that may be effective for vaginal dryness. And PRP is platelet-rich plasma. That may be a potential treatment for you that can not only help with dryness, but for some can help with libido and orgasm as well. And then if you have pain or scarring of the vagina, using dilators and a pelvic floor PT may be very beneficial. I would strongly recommend that if you are not getting the answers from your oncology team or your current gynecologist, seek out a sexual health specialist like myself, because we talk about this day in and day out. So it's something you do not need to be embarrassed about, and we have a lot of recommendations for whatever specific issues you're experiencing. All right, so moving on to maintaining wellness. So in general, a healthy lifestyle, weight control, diet, and exercise, is really good for everybody. But what we found in cancer survivors, it actually improves the prognosis, the outcomes of their treatments. It decreases symptoms, and in some studies has actually been shown to decrease recurrence risk. And I do believe for breast cancer that that holds true. It also reduces the risk of new malignancies, as well as other comorbidities and overall mortality. So it is really important. Now, the most important thing, so more than any medicine in any field of medicine can do, is exercise. So it improves physical health, it improves mental health. Really, exercise is invaluable. What they found for cancer survivors that it may improve fatigue, distress, and overall quality of life. But it can be very difficult. If you've undergone surgery and have limitations, you may be hesitant or have actual difficulty performing exercises that you previously did. So there are lots of resources in different organizations of exercises that may be beneficial for you after surgery, but also getting a physical therapist or a trainer that is knowledgeable can be really helpful. And what the guidelines recommend now is 150 minutes of moderate or 75 minutes of vigorous exercise, and 2 days a week of strength training. Strength training is really, really important to help with weight control, to help with osteoporosis prevention, as well as inflammation and metabolism. So I do recommend not just cardiovascular, but also strength training. And then in terms of wellness, as I mentioned before, stopping smoking is probably one of the, after exercise, the second most important thing that you can do. In cancer survivors, the use is actually similar to the general population. But what is really surprising and frustrating is that young survivors are actually more likely to continue smoking. And that, is really upsetting, as that puts them at major risk for other cancers as well as recurrences. For quitting smoking, the most effective combination is including counseling or a support group with medication or a quitting aid. So either one alone is better than nothing, than just trying to quit cold turkey. But there's lots of data saying that the combination of support and medication or a quitting aid is the most effective. Now, in terms of alcohol and drug abuse, luckily that is slightly lower in the cancer survivor population, but can be increased in those with PTSD or other mental health issues. One thing that I want to bring up here as well is that there's a lot of data suggesting that siblings of cancer survivors, especially if they are young at the time of their diagnosis, have increased rates of substance abuse. So that's something that, while it is not necessarily your job to monitor that for a sibling, if you think that they are having an issue, it's worth discussing that and reaching out to see if they would like help. All right, so what can I do? So before you start treatment, from the moment of diagnosis, if you are going to be sexually active with a male partner, consider contraception. Discuss menses and ovarian suppression with your gynecologist, and make sure you're up to date with your PET and HPV testing, and consider the HPV vaccine. Discuss fertility preservation if you're interested. Even before treatment, find out about support groups and counseling, because that may make the process of undergoing treatment more comfortable. Understand that what sexual concerns might arise and what to do when they do. And discuss your plan to return to your gynecologist, the timing once your cancer is treated. After treatment, make sure that you request a survivorship care plan from your oncologist with the information about your treatment and follow-up. Follow through with your appropriate cancer screening. Look for signs of diminished ovarian function and discuss that with your providers. Talk to your provider about anxiety, depression, and sexual dysfunction, and understand the importance of exercise and maintaining healthy weight. Thank you.